Cephalosporins are another type of beta-lactam antibiotics. Their structure also contains the beta-lactam ring that we saw in penicillins, and along with that, we have a dihydrothiazine ring and an acyl side chain. Like penicillin, cephalosporins also have a fungal origin and thus will be associated with hypersensitivity reactions. First, originally they were discovered from a fungus, and then later semi-synthetic forms were developed. The mechanism of action is similar to that of penicillin, that is cell wall synthesis inhibition. That's why they are bactericidal, and the resistance modes are the same as that developed for penicillins. Now, there are some bacteria or pathogens that are not covered by cephalosporins. The mnemonic that we can use to remember these pathogens is atypical Mr. cannot enter the list. Now, atypical stands for the atypical bacteria, that is, they are wall-less and live intracellularly, for example, mycoplasma and chlamydia. The Mr. stands for MRSA and enter for enterococci, while list for listeria. Now, if you remember, listeria was covered by ampicillin in the penicillins video. Now, one thing to remember about their pharmacokinetics is their excretion. Most of them are water-soluble and thus are actively secreted in the tubules of the kidneys, except ceftriaxone and cefoperazone. This is not cefoperazone, it's cefoperazone. Both of them are lipid-soluble and thus are excreted via the liver. As I said, renally they are excreted via active tubular secretion, and they can also be blocked. Their secretion can also be blocked by competing with probenecid. Probenecid wins, just as it won in penicillin case, and thus their therapeutic concentration will increase and their plasma concentration half-life will also increase. Now, they have some degree of nephrotoxicity, and as well as they are excreted by the kidney, so their dose needs to be adjusted in some renal diseases, while the dose of ceftriaxone and cefoperazone need to be adjusted in hepatic dysfunction. As I said, ceftriaxone and cefoperazone are very lipid soluble. You might expect cefoperazone, and both of them actually, to cross the blood-brain barrier and help in meningitis cases, but that's not the case with cefoperazone. The reason is that it is very, very lipid soluble, okay? So it will also have a very high plasma protein binding and thus a decreased free fraction that is available to cross the blood-brain barrier. So it cannot be used in the treatment of meningitis. Before seeing the different generations of cephalosporins, let's see some side effects. First is hypersensitivity. This is because cephalosporins are originated from fungi and also have a sulfur group. The hypersensitivity can be of two types. One is partial and the other is complete. If a patient is allergic to penicillins, then there is a partial chance that he or she will be allergic to cephalosporins as well. But if the patient is allergic to one type of cephalosporin, then there is complete allergenicity to the other type as well. In cases of allergies to cephalosporins and when we are dealing with gram-positive organisms, we can use monobactams, or if we are dealing with gram-negative organisms, then we can use macrolides in place of cephalosporins. Two of the cephalosporins have disulfiram-like actions and thus will cause intolerance to alcohol. They are cefoperazone and also cefetitin. They will thus inhibit the enzyme acetaldehyde dehydrogenase and thus cause the accumulation of acetaldehydes and cause all the negative symptoms that we've discussed in the video regarding alcohols. They can cause GI distress as well, just like penicillins, and cause a C. diff infection and also diarrhea. Cephalosporins and penicillins can both cause the body to form antibodies against the red blood cells by adhering to the cell membrane of the RBCs. So they will have a positive Coombs test, but rarely hemolytic anemia. Coombs test is a blood test to check if your RBCs have antibodies attached to them, and it can be direct Coombs test that will detect the antibodies that are attached to the RBCs, and indirect Coombs test which will detect the antibodies that are present in the serum. Lastly, there can also be severe bleeding and it can be due to hypoprothrombemia, thrombocytopenia, and platelet dysfunction. Now that we're done with everything else, we'll look at the 5 generations of cephalosporins and make it easy to remember. There are the first, second, third, fourth, and fifth generations. Now the first cephalosporin generation will contain the drugs that will have PHA, FA, or PHRA in their names, except cefaclor that also has FA. It is in the second generation. While the third generation will have IME, 1, 10, or IR in their names, except cefuroxime, which is also from the second generation. The drugs which have PI in their name are from the fourth generation and INE from the fifth generation. We'll only discuss one drug from the fifth generation. Now remember, I've only made these combination of letters for you to remember them, and there can always be exceptions from these, but these are the most important ones that you need to remember. Coming to some examples of the first generation, they can include cefazolin, cephalexin, and cephridine. You can see they have FA, PHA, and PHRA in their names. The second generation will of course include cefaclor and cefuroxime, as we've already seen, and also cefotitin. This is written in some books with TET and some books with TIT. From the third generation, the most important one is ceftriaxone. Now if something happens and you're about to forget everything, just don't forget about ceftriaxone from the third generation. It also includes cefotaxime, cefixime, cefdinir, and ceftibuten. The fourth generation, only one drug we'll see. It's cefepime. It contains PI in its name. And the fifth generation has ceftazoline. Now coming to their action, that is which bacteria they are good against. Now as a general rule, just remember that the gram-positive activity will decrease as we go from the first to the fifth, while the gram-negative activity will increase as we go from first to fifth. So first generation will have immense gram-positive activity and also some gram-negative activity and activity against anaerobes except Bacteroides fragilis. The second one will have gram-positive and gram-negative, but you can see that the gram-negative activity is increasing and anaerobes except B. fragilis. The third generation is the broad spectrum, is the one with the broad spectrum. It has the greatest activity against gram-negative, both cocci and rods, and also against gram-positive and anaerobes, including Bacteroides fragilis. The fourth generation will have the same effects as the third, but not an activity against Bacteroides fragilis. Lastly, the fifth generation are most commonly used against the most common mutations in the penicillin binding proteins in MRSA cases. Let's now see if they have the ability to cross the blood-brain barrier or not. The first generation cephalosporins generally do not cross the blood-brain barrier, while the third generation cephalosporins can cross the blood-brain barrier. Now the second generation can be imagined as to be in between 1 and 3, and generally it cannot cross the blood-brain barrier, but cefuroxime can cross it. Now to remember this exception, as I previously mentioned that all drugs with IME will be in the third generation, and it's a property of the third generation to cross the blood-brain barrier, but an exception is cefuroxime, which is actually a second generation, so it will share one property with the third generation, and thus it can cross blood-brain barrier unlike the second generation. The last two generations can also cross the blood-brain barrier. Among the first generation, cefazolin has a long half-life and can be used for surgical prophylaxis. The first generation are not resistant to beta-lactamases produced by bacteria. Among the second ones, as I said, cefuroxime will cross the blood-brain barrier, so it can be used in meningitis, and resistance shown to beta-lactamases is only by cefuroxime and cefoxitin. The third generation cephalosporins can be used to treat severe gram-negative infections, and most of them are resistant to beta-lactamases except cefoperazone. The fourth and fifth generation cephalosporins are also resistant to beta-lactamases. That's all, but remember that the resistant properties of these beta-lactamases are not carved in stone, and bacteria are constantly producing new ways to become resistant to all antibiotics.